next country, and he will be talking on the aortic valve replacement. How do you do? Sometimes this procedure end up with nightmare to many surgeons all over the world. Now I invite our Professor Farooque Ahmed sir to deliver his speech. Thank you, sir.
Assalamu alaikum, all learned audience. Here is about to say how we perform AVR. All of us sitting here are doing regularly this aortic valve replacement. Is not a big deal. So there are some upcoming surgeons, for them, they are also doing this aortic valve replacement. I'll just add some few points so that things are made little easy for them to do. That's all. Nothing else, nothing new. The same books you are reading, we have read the same books. And it has been described in the books, we follow the books, and that has been taught by our teachers. So, just as it is a lecture, so few words about this valve history. First, digital aortic dilatation was done in 1912 by Taffier, but it was not of success. Later than in 1940s, Bailey and Kirkland, all this tried, they failed. But in 1954, Hafnagel reported a valve in descending thoracic aorta for AVR. And from basically it took the journey in 1960. This Star Edwards ball and cage valve revolutionized, and there is the benchmark for valve surgery. And at the same time, Carpentier produced this tissue porcine valve, glutathione. And now these days we are using mechanical valve, bileaflet. Initially it was single leaflet, now it is bileaflet valve. We do aortic valve replacement for this aortic stenosis and regurgitation. These are all theoretical interest. I don't find any reason to go for this thing. So, and as you said, these days everything, what is the recommendation, what is the guideline? This peculiar thing has come up. Whatever you say, whatever the cardiologists say, when they land up with problem, this is the guideline. Otherwise, they are on their own, they are whatever they like, they are doing. But when they land up with problem, then they ask the question of guideline. So there is also a guideline, and we are following the guidelines, same guidelines everywhere in the world. We are already following it. As pre-aortic depression, as you know, in addition with the aortic valve, we miss something or the patients come late to us. They have this palpable fever and palpable liver and the high proBNP. ProBNP is important because this, if you do the surgery after controlling the failure, the recovery is better, and the patient does well if the failure is controlled, and the outcome is also good. If we do operation in the failing heart or in patient with the heart failure, we will find difficulty in come out of the bypass in the aortic, and at the same time we learn that the problem in the ICU also. So these are the two things to be taken care of. And at the same time, one more thing I try to draw your attention. These days we find lot of subclinical hypothyroid in our country. Lot of subclinical hypothyroid there. What is the problem with the hypothyroid? In the post-op period or on the table, we go on pushing the inotropes and the heart is not picking up. So if the thyroid function is controlled and taken care of, in the postoperative period they will do well. And of course, this lung function. Lung function is all important. If we do the lung function and see if there is a problem with the lungs, or if give the patient this exercise, lung exercise with the medicizer or this incentive spirometry, that helps in the postoperative recovery. About the valves, mechanical and bioprosthesis. About this mechanical, normally we use mechanical valves between up to 50 to 60, and after the tissue valve, and tissue valve is after 65 or 70. In the middle of 55 to 60, or 50 to 60, this is a gray zone. It depends on the choice of the patient, choice of the surgeon, and type of the disease. And then one more thing, this TABI. TABI is specifically for more than 75 years of age. Patient should be more than 75 years of age, and he cannot stand this big surgery, have so many comorbidities, then we can think of TABI. Otherwise, it is surgical AVR or SABR. As a result, commonly, generals putting the patient on cardiopulmonary bypass, and I myself like bicable cannula. Previously used to this two-stage single venous cannula. Still, while we do the mini sternotomy, we can go with the single cannula, but preferably two cannula. It gives good cooling of the heart, and at the same time, I can do the retrograde cardioplegia by making a small leak in the right atrium. Retrograde cardioplegia helps me in saving times. While we get the patient heart arrested by giving antegrade cardioplegia, and after that we introduce the retrograde, and while we are working or on the valve, when the cardioplegia repeat time comes, it is the perfusions he or she can give it to the retrograde, and I can have, at the end of the process, I can have this 5, 10 minutes, 15 minutes less. So that's of benefit. And during this bypass, we should take care of this, especially with aortic stenosis, the amount of cardioplegia should be double the dose of normal, because the muscle is very thick, that's why. And two things to be maintained for good outcome. One is the myocardial protection, and another is the tissue perfusion. For that temperature, that flow, the tissue perfusion should be good enough. And if the tissue perfusion and the myocardial protection is maintained, then I can tell you, you will come off bypass smoothly and the patient will get well without any problem. So the aortotomy, what we practice is, there are two types of aortotomy can be done. One is this oblique, another is transverse. Oblique means hockey stick, about 10 to 50 millimeter above the aortic root or above the orifice, external orifice of the, the origin of the coronary, right coronary. A nick is made, then it is extended obliquely towards the opposite side, and after seeing the side, to take the incision down to the middle of the non-coronary, towards the middle of the non-coronary. So that's the hockey stick incision. And of course, it can be done by transverse aortotomy. We do just transverse aortotomy, and then we do the cardioplegia selective. And one more thing, before starting the cardiopulmonary bypass, the bed should be there through the right upper superior pulmonary vein into the left ventricle. And in case of aortic, for beginning the cardioplegia, cardiopulmonary bypass, one should keep it in mind. First to drain the heart, little drain the heart, and then to advance. This is a picture of this insertion of the retrograde cardioplegia. And aortic valve cusp removal, ideally and technically it has been said, and it's possible in regurgitation, to cut the valve through the middle of the right coronary cusp, and then going anti-clockwise to the left and non-coronary commissure, and coming clockwise, the valve is excised. But in case of aortic stenosis, all of you encounter and see the calcification, you feel like running away from the aortic. It's a solid pillar of cartilage or bones, like calcification. So in that case, how do you identify this right coronary and non-coronary? What we practice, we take the Kelly forceps, slip it through by the side of the calcification to the groove or annulus level and crush it. With this, usually the valves get separated or get the cleavage, and we get a line of tissue for holding the stitches. As it has been said in the book or written in the book, calcification to be removed by rongers. If we do it, we practiced, and so we remove it in complete removal of calcification, and later on when we put the stitches, it cuts through. But if we do it by crushing with the Kelly or long carved artery forceps, it leaves a rim of tissue and at the same time comes out cleanly and give good area, and it is faster than this rongers technique, number one. Number two, with this, if the calcification extends to the LV wall or the aorta, a chunk of endocardium may come out with these things. In that case, what we do, we put the pleasures inside the LV side. So while taking the bites inside, taking the fixing the separated endothelium with the ring, and there is no leak or anything. So this is what is one of those calcified valves. The crushing with the this is how we crush it and extract the valve. Get a cleavage and we go through the cleavage. This is a crushing and then to take the stitches, the pleasures are put inside the LV. And here also a chunk of endothelium came out with the calcium, and while taking the bites, we fix it with these pleasures. And about sizing of the valves, you don't have to worry about this. The app is there. You see the app, you know which size of the valve and which type of valve you can put. It is there. So no tension about patient processes mismatch. This is the onyx confront, this narrow rim of stitching. This is how it looks while about to finish, and closing the aorta in 2 layers. And usually the patient with this AVR, after AVR, may need some inotrope with coronary with peripheral vasodilator. There goes reflex vasoconstriction, so pressure goes up, and you need the vasodilation to get a good cardiac output. Otherwise, with aortic stenosis, if the myocardial protection is good, and if you take not too long, usually don't require any inotropes. And if be needed, then you can add it later on, a small amount of dobutamine. And one more thing, after doing the replacement, you should at least wait 8 hours before extubation, because usually there is a rule of thumb, after shifting the patient, maximum myocardial edema takes place after 8 hours, and then it gradually subsides. So if myocardial edema is there, there will be contraction problem. After that, if the patient remains well, sinus and doing well, no inotrope required, you can go for extubation. Better to extubation next morning. And about this anticoagulation, in case of aortic valve, we follow the formula INR 1.5 to 3. But with onyx valve, I'm not promoting, but it is said that with onyx valve, the little lower side of INR is good enough, and it usually doesn't cause any problem. And one more thing, keep it, I want everybody, I have seen these patients dying suddenly of the aortic valve patient, even after replacement. They have a tendency to arrhythmia, fatal VT or fibrillation. There is a typical peculiar history. Patient was doing all right after 1, 2 months, 3 months. Patient came out from the toilet and slept, and he's not waking up. Sudden cardiac arrest. To prevent that, either of the 2 drugs, either an amidiron or some beta blocker, should be added without hampering or controlling the blood pressure. If we need it, control the blood pressure. If the problem is not with the pressure, then amidiron or some beta blocker at least 1 year. That will help you. Thank you very much.